bit of an outline of what we'll go over today. Again, we'll talk about a general algorithm for how to approach solid lesions in the pancreas. Then we'll look at some features specific to invasive adenocarcinoma and compare that to what we see in chronic pancreatitis. And we'll talk a little bit about how those can be useful for frozen section diagnoses as well. Next, we'll talk about some special subtypes, more unusual types of pancreatic carcinomas. And then at the end, we'll do a couple of illustrative cases of some unusual things that we've seen here. So first, when we think about lesions of the pancreas, we can broadly divide them into solid and cystic neoplasms. And this is often the easiest question we get when we're looking at these things. And when we just look at the gross, we can see a clear difference. You have a nice solid mass, space-filling lesion within the pancreas versus a cystic mass with lots of septation and open spaces. And that's kind of our easy question to answer, if it's solid or cystic. So we'll start with a case. First, we have a 70-year-old man who underwent a partial pancreatectomy for a suspected adenocarcinoma that had the following gross appearance. So here's our lesion. We can see a little bit of normal pancreas here, and we can follow that pancreatic duct back, and all of a sudden it abruptly narrows and stops, and then we have this large lesion that sort of looks grossly infiltrative, right? We can sort of see it creeping into fat. It has this very dense, serous look, very fibrotic, very irregular border. So we know we have a solid neoplasm in our algorithm. And the first question we ask when we have a solid neoplasm is it hypocellular or cellular? And so we're looking at the nature of the epithelial and stromal components within the lesion. So by hypocellular, we mean we have a lot of individual glands, desmoplastic stroma, and maybe some mucin production. Versus cellular, we think of a very solid neoplasm, lots of cellularity, minimal or maybe hyalinized stroma. So just to illustrate what those two things really mean, if we're talking about the nature of the epithelium and stroma, here on the left, we have a hypocellular lesion with sort of desmoplastic stroma. And on the right, here's what we mean by a cellular lesion. Very little stroma, maybe a little bit of minimal hyalinization, but most of your tumor is comprised of cells. All right, so here's a microscopic slide of the case we looked at originally, and we can see that we do again have desmoplastic stroma and lots of infiltrating cells. So this is a very challenging case. We can really see those cells infiltrating into normal pancreas. They have lots of marked cytologic atypia. We even see single cells. This is a fairly straightforward example of an invasive adenocarcinoma of the pancreas. So again, we have individual glands with abundant stroma, and so our two main diagnostic choices are either chronic pancreatitis, here at the bottom left, or invasive ductal adenocarcinoma. And so sometimes it's not quite as clear as it was on our initial example. And in that case, we have several useful morphologic features that we can use to try to distinguish between a chronic pancreatitis, a benign proliferation of ductal elements within the pancreas, and an invasive ductal adenocarcinoma. And so those 6 features that we use are a haphazard growth pattern, incomplete lumina or luminal necrosis, nuclear variation, so size variation greater than 4:1 within the same gland. And then 3 features at the end that I sort of like to think of as cells where they don't belong. So the first being the growth of glands next to large muscular vessels, perineural invasion, so glands actually involving a nerve, or vascular invasion, so epithelial cells invading into either lymph spaces, arteries, or veins. So again, this example was pretty straightforward. We can see quite clearly that we have an infiltrative growth pattern, that we have great nuclear size variation within individual glands. We have, again, that haphazard growth pattern. So in some cases, though, it's just not as clear as our original example. So here's a section that actually came from the pancreatic neck resection margin from a Whipple specimen. And we can see that while lots of the pancreas looks really happy, normal lobules with ducts in the center, you do have this little area of proliferation of glands here that's not quite clear what's going on with them. So let's look at a little bit higher power. Here we can see they're mucinous, but they have fairly bland nucleus, and it's not obvious that they have an infiltrative pattern. You could argue, you could sort of draw a circle around them and they're still fairly lobulated. Here's another area from the same case. Again, here's some vessels, and here's these, again, very bland glands sort of hanging out around them. And again, another image at higher power, we can see there's not a lot of cytologic variation, lots of mucin, which we don't typically see in pancreatic ducts. But what's really the nature of these glands? Are they reactive? Could they be pannin, so pancreatic intraepithelial neoplasia, so a precursor lesion to an invasive adenocarcinoma? Or does this, does this reflect a really bland gland of an infiltrating adenocarcinoma? So this is where these 6 features that help us to distinguish between benign proliferations like chronic pancreatitis and adenocarcinoma really come in handy. So again, we'll go through each one: haphazard growth pattern, incomplete luminal necrosis, nuclear variation greater than 4:1, growth next to a muscular vessel, perineural invasion, and vascular invasion. And we'll look at examples of each of these.